Coronary syndromes, Part 5. Complications. Complications are seen in all forms of acute coronary syndrome, although the frequency and extent vary with the severity of ischemia and infarction. Major mechanical and structural complications are seen only with significant, often ST elevation transmural infarctions. Arrhythmias. Many patients with acute coronary syndrome have some form of arrhythmia. In the majority of cases, this is transient and of no hemodynamic or prognostic importance. This slide lists the arrhythmias that might accompany acute coronary syndromes. Of course, I want you to take care that ventricular fibrillation, ventricular tachycardia, atrial fibrillation, sinus bradycardia are the most serious of the arrhythmias that occur in association with acute coronary syndromes. Ventricular fibrillation. This occurs in 5 to 10% of patients who reach the hospital. It is also thought to be the major cause of death in those who die before receiving medical attention. Prompt defibrillation is a life-saving measure. Prognosis of patients with early ventricular fibrillation occurring within the first 48 hours and who have been successfully restored to the sinus rhythm is similar to prognosis in patients who did not sustain a ventricular fibrillation. It's also worth noting that around 50% of patients with a massive heart attack or an ST elevation myocardial infarction never make it to the hospital, which means that there is a considerable percentage of patients who sustain a ventricular fibrillation before reaching the hospital. Atrial fibrillation. This is common but frequently transient and usually does not require emergency treatment. If associated with a rapid ventricular rate and hypotension along with circulatory collapse, cardioversion with immediate synchronized DC shock is essential. Otherwise, beta blockers would be the treatment of choice. Atrial fibrillation due to acute atrial stretch is often a feature of impending or overt left ventricular failure, and therapy for atrial fibrillation may be ineffective if heart failure is not recognized and addressed appropriately. Anticoagulation is required if atrial fibrillation persists. Bradycardia. If there is hypotension or hemodynamic deterioration associating bradycardia, atropine in a dose of 0.6 to 1.2 milligrams intravenously might be given. Atrioventricular block complicating inferior infarction is usually temporary and often resolves following reperfusion therapy, but may persist over the first 24 hours following reperfusion. If there is clinical deterioration due to second-degree or complete AV block, a temporary pacemaker should be considered. AV block complicating anterior infarction is more serious because asystole may suddenly supervene and a prophylactic temporary pacemaker should be inserted under all circumstances in such situation. Patients who develop recurrent angina at rest or on minimal exertion following an acute coronary syndrome are at high risk and should be considered for prompt coronary angiography with a view to revascularization. Patients with dynamic electrocardiographic changes and ongoing pain should be treated with intravenous glycoprotein 2b3a receptor antagonists. Patients with resistant pain or marked hemodynamic changes should be considered for intra-aortic balloon counterpulsation and emergency coronary revascularization. Should you have any questions or inquiries regarding what intra-aortic balloon counterpulsation is and how it works and how it maintains the tissue perfusion, don't hesitate to address this in the face-to-face mini lecture. Post-infarction angina occurs in up to 50% of patients treated with thrombolysis. Most patients have a residual stenosis in the infarct-related vessel, despite successful thrombolysis, and this may cause angina if there is still viable myocardium downstream. For this reason, all patients who have received successful thrombolysis should be considered for early within the first 6 to 24 hours coronary angiography with a view to coronary revascularization. Acute circulatory failure. Acute circulatory failure usually reflects extensive myocardial damage and indicates a bad prognosis. All the other complications of myocardial infarction are more likely to occur in patients when acute heart failure is also present. Pericarditis. Pericarditis occurs only with infarction, meaning that it does not happen in patients with unstable angina. Onset is on the 2nd to 3rd day post-myocardial infarction. A patient notices a different character of pain. Pain is positional, sometimes only perceived during inspiration. Opiate-based analgesia is the treatment of choice, and non-steroidal anti-inflammatory drugs should be avoided because they increase the risk of ventricular aneurysm formation in such setting. Post-MI syndrome. The post-MI syndrome, also known as the Dressler's syndrome, is characterized by persistent fever, pericarditis, and pleurisy. It has an autoimmune etiology. Symptoms tend to occur a few weeks or even months after the infarct. This syndrome often subsides after a few days. High-dose non-steroidal anti-inflammatory drugs, aspirin, and possibly corticosteroids in resistant cases. Mechanical complications. Part of the necrotic muscle in a fresh infarct may tear or rupture with devastating consequences. Rupture of the papillary muscle leads to acute pulmonary edema and shock due to the sudden onset of severe mitral regurgitation, which presents with a pansystolic murmur and a third hard sound. In case the regurgitation is very severe, a murmur might not be heard. The diagnosis is confirmed by echocardiography, and emergency valve replacement may be necessary, and this is usually the case. In case you have any questions regarding why mitral regurgitation murmur is not heard in severe cases, please don't hesitate to address this in the face-to-face mini lecture. Rupture of the intraventricular septum. It causes to left to right shunting through a ventricular septal defect. A new loud pansystolic murmur radiating to the right sternal border is heard. Patients tend to develop right-sided heart failure rather than pulmonary edema. Doppler echocardiography and right heart catheterization will confirm the diagnosis. Without prompt surgery, the condition is usually fatal. Rupture of the ventricle causes cardiac tamponade and is usually fatal. Incomplete rupture may occur, in which case it might be possible to support the patient briefly until emergency surgery is performed, but surgery remains emergency in such case. Embolism. Embolism might occur due to thrombus formation on the endocardial surface of a freshly infarcted myocardium. This might lead to stroke or other forms of systemic embolization like ischemic limbs. Remodeling. Acute transmural or ST elevation myocardial infarction is often followed by thinning and stretching of the infarcted segment, which is called infarct expansion. This leads to an increase in wall stress with progressive dilatation and hypertrophy of the remaining ventricle, what is called ventricular remodeling. Infarct expansion occurs over a few days and weeks, but ventricular remodeling can take years. ACE inhibitor therapy reduces late ventricular remodeling and can prevent the onset of heart failure. Ventricular aneurysm. A left ventricular aneurysm develops in approximately 10% of patients with myocardial infarction. Ventricular aneurysm is more common in patients with persistent occlusion of the infarct-related vessel. Heart failure, ventricular arrhythmias, mural thrombus, and systemic embolism are all recognized complications of aneurysm formation. Echocardiography is diagnostic in ventricular aneurysm. Aneurysmectomy carries high morbidity and mortality, but is indicated when there is recurrent ventricular tachycardia and fibrillation secondary to ventricular aneurysm formation. End of part 5 and end of the lecture, acute coronary syndrome. Thank you very much.